Hello, my name's Scott Harding-Lister and I'm the Senior Expert and Head of Practice here at Apex Health Associates. Welcome to our brief exploration of the Braden Scale, a critical instrument in the fight against pressure injury. As healthcare professionals, our commitment to patient care extends beyond treatment into prevention. Today, we'll uncover and look at the layers of this pivotal tool, its history, the global impact, and the nuances of its application within the clinical setting. The Braden scale is also referred to as the Braden Score, or sometimes the Braden tool. So throughout this presentation, we will refer to all three, as all three are often used within clinical practice. The Braden scale is not merely a checklist, it's a healthcare tool guiding nurses and caregivers in the early identification of pressure injury risk. There are many similar tools being used within primary and secondary care. In a previous video, we looked at the Waterlow score, and the Waterlow score was developed by the nurse tutor Judy Waterlow around the same time as when the Braden score was created. The Braden tool is a clinical ally and sets the legal standard for pressure risk identification in the organisations where it is used. The genesis of the Braden scale is as compelling as its application. It was conceived from a need to better understand and quantify the risk factors associated with pressure injuries. Through the Robert Wood Johnson Teaching Nursing Home project, a scientific foundation was laid down. The ensuing years saw its rigorous validation, and by the time its findings were published in 1987, the Braden scale was poised to become a cornerstone of patient assessment. The reach of the Braden scale is a story of its own, from the hospitals of major cities to small clinics in rural areas across the world. The scale's adoption has been widespread. At its core, the Braden scale is a composite of 6 criteria. Each serves as a window into the patient's vulnerability to pressure injuries. These criteria are: number 1, sensory perception; number 2, moisture; number 3, activity; number 4, mobility; number 5, nutrition; and lastly, number 6, friction and shear. Scoring the Braden scale is a delicate balance. It's a numerical expression of a patient's condition, but behind each number is a narrative of their current health status. A lower total score signals a higher risk of ulcer development, necessitating a nuanced interpretation and a tailored, individualized and robust care plan. Note that with some of the other scores, such as a Waterlow score, the scoring system here is different. The lower the score, the higher the risk. The Braden scale's relevance can extend beyond the clinical realm into the legal framework of healthcare. It serves as a litmus test for standard of care, offering a benchmark against which practices can be measured. If a complaint or negligence is raised by a patient or service user, then the assessment of the patient's risk using a validated scoring system such as the Braden score will be considered, and how that identified risk was mitigated. To illustrate the Braden scale in action, let's look at the case of Mrs. Smith. Mrs. Smith was a 78-year-old lady who had a previous medical history of diabetes, and she had reduced mobility at home. She was admitted to hospital as an emergency due to a fractured hip. Using the Braden scale, the nursing team assessed her risk and noted that she was at high risk of developing a pressure injury. For sensory perception, they allocated 4 points because they found there was no impairment. For moisture, they allocated 2 points because there was sometimes some moisture on her skin, but not all of the time. For activity, they allocated her 1 point because she was bedfast and she was confined to her bed. For mobility, they allocated 2 points because she had very limited mobility and she could make slight changes in her body position. For nutrition, they allocated 3 points because clinically it was decided that she had adequate nutrition. For friction and shear, she was allocated 1 point because she required maximum assistance in moving. So this assessment and identification of Mrs. Smith's high-risk status enabled the implementation of a comprehensive and robust individualised care plan, including regular repositioning, specialist services for both her bed and chair, mobility aids, dietary and hydration monitoring, continence aids, and careful monitoring of her skin by regular skin inspections. This proactive approach effectively prevented pressure ulcers. The condition of Mrs. Smith's skin was monitored with regular skin inspections, and the care plan and interventions were amended as and when her condition changed, in line with the local policy and nursing judgment. The Braden Score allowed for a standardised process to be followed and the level of risk to be communicated. To conclude, the Braden scoring system is an excellent clinical tool in helping identify those at risk of pressure injury. Pressure ulcers can be a significant and horrific injury that can take significant time to heal. My own personal criticism is that the tool does not take into account that a patient may have suffered a pressure injury in the past and therefore at high risk of developing another. The Braden scoring system is good, but it should never be solely relied upon and replace clinical judgment.